Morning, good afternoon, and good evening to everyone, wherever you are in the world. We thank you for making time to join this special session. I'd like to thank you on behalf of the WHO, the World Bank, and the BMJ Collection on Quality of Care for joining today's official launch of the collection. As you can see from the slide, next slide, please. Today's program, we have a very interesting agenda designed for you. After opening remarks from representatives of the WHO, the World Bank, and the BMJ, we will proceed to 3 panel discussions focused each on one of 3 themes, as you can see in the slide: creating an enabling environment for quality of care, engaging for quality of care, and innovating for quality of care. Following each panel, there will be a brief moderated Q&A, and we will also continue the discussion and invite you to continue the discussion in a virtual discussion forum that will be shared with you a little bit later in this session. A few housekeeping items. We'd like to ask you to introduce yourself in the chat, and thank you to the many of you who are introducing yourself. All of the collections are freely available to read, open access on the BMJ website. And you should see in the link, the link to the BMJ landing site for the collection. The recording and presentation slides will be posted to the Quality of Care Network website and will be shared via email with all of you who have registered and are participating today. And as mentioned, we have created a virtual discussion platform that was established specifically for this webinar, and we invite you to continue today's discussion in that virtual platform, and you will see the link in the chat. It is now my pleasure to invite our speakers to provide opening remarks. I'd like to begin by inviting Bruce Aylward, Assistant Director General, WHO, to share reflections with us. Over to you, Bruce.
Thank you very much, Kathleen, and good morning, good afternoon, and probably good evening to some of you who are all joining us on the call today. Look, I want to say a few comments about the collection and about our discussion today, but I first just want to thank all the people who have gotten online to be part of today's discussion and participate. I'm just watching the list of participants as it ticks up, and we're already over 250 people, which is fantastic, and which reflects, of course, just the importance of this issue that we're discussing here today, and that BMJ and our partners at the bank and elsewhere have done so much work on in putting together the collection. And that is, of course, the crucial issue of ensuring quality of care and quality of health care. As many of you know, probably one of the most staggering and deeply concerning figures and statistics that are out there when we talk about healthcare is that 50%, which is, of course, the number of preventable deaths that are accounted for by poor quality care. This is a staggering number and something that we really have got to do something about. And again, the number of participants, which is now creeping up to over 300, I think really emphasizes that this is not just a concern of WHO, the World Bank, BMJ, but also of so many countries. I see the many country representatives that we have online and so many of our partners. The timing for the release of this collection is really important because what it contains, as many of you have seen, is an awful lot of very practical experience and guidance from many countries as they look to how they move forward in their specific contexts on the issue of quality and quality of health services, but while respecting some of the big themes that we'll talk about through the panels and elsewhere. It's also occurring at a time, it's coming just 6 months after we released, or rather 4 months, with the bank, our global monitoring report on universal health coverage that shows a huge gap in access to services that there is worldwide. but doesn't quite hammer that point home enough about the challenge in the quality of that care that is being delivered. So as we move forward, there's great buy-in around the world now to utilizing a primary healthcare approach to accelerate progress toward universal health coverage, but it is essential that that approach be anchored in quality, obviously, and quality of care. As we look now in the way forward, we've seen as well in many of the documents, the comments in the collection, achieving a quality-driven health system is not straightforward, but there are certain aspects of it that are common. The first is the absolutely vital need for political commitment to lay out the vision, the commitment, the values that underpin this, as well as the priorities for going forward. But that political commitment, again, as we see throughout the collection, will only work if it is translated into and operates in a strong enabling environment that consists obviously of the right workforce, an informed workforce, the right financing, obviously, and putting people obviously at the center of the approach. The other thing, though, that we've learned is even with all of that, we've got to remember it cannot be delivered quality in a vacuum. It really requires the engagement of all actors, another common theme that comes out throughout the collection. And these actors include, of course, community organizations and civil society organizations, many of whom are participating today, academia, who contributed so much to the collection, professional associations, as well, critically, of the private sector, which we'll hear a little bit more in the discussions today. But as we go forward, this is hard work. And it's got to be a combination, we're learning, of obviously continuous improvement to use data and information to continually identify problems and tackle them piece by piece as we move forward. But that continuous improvement also needs to be informed by innovation. Another big theme that comes through the collection, just the tremendous innovations that have come from so many different areas in so many different countries, anchored in that fundamental need to achieve quality of services, to ensure they are both effective, but also that we maintain trust critically with the communities that we serve. There's a lot of great promise in these innovations. Further implementation research obviously needed, but all of it points to what is a solvable problem if we start with that political commitment, build on it through the enabling environment, a few elements of which I have just spoken to. As we look forward, we've got to be super clear. This is the perspective of the World Health Organization, of course, the World Bank, whom we work with. Monica, I'm going to say this on your behalf and all of our partners, in that this is not an option. It is not a nice to have. It is an absolute essential to have a quality at the center of what we're trying to do as we strengthen the delivery of health services. It's got to be right at the center of how we think about redesigning, re-engineering our services as well, in the face of so many challenges in front of us, whether the changing demographics, the changes brought with climate change, the epidemiologic shifts, or the others, of which are all requiring us to constantly rethink our health systems and services and how we deliver them. But again, one thing in common, irrespective of the challenges, irrespective of the setting, it's got to be quality care for everyone, everywhere, and all the time. As I wrap up, I just want to take a moment to thank those who have helped make the collection possible and the discussions that we'll have today. So first, I just have to thank you, Karim, and everyone, Kathleen, there at BMJ for your leadership, such a prestigious journal, seeing this as such a priority and working with us to put together the collection that we're going to discuss today. I also want to thank the Bill and Melinda Gates Foundation. It's always important to thank those who support your work and support it financially, because otherwise we wouldn't be able to do these things. So thanks to the Gates Foundation, who I hope are represented here today and can hear that. And of course, the great collaboration with our bank and WHO colleagues. The last thing I'd like to do is just thank all of the authors who contributed, as well as the editors, and then the panelists, some of whom you've already heard from as we were warming up here today, who have joined today to be able to share some of the experiences that underpin the collection and help to bring some of the content alive for all of us so that we understand even better what it means to enable, engage, and innovate for quality services. So thank you all very much for a few moments to say a few opening comments about the importance of this issue, the promise of a way forward, and just the fundamental need to ensure, once again, that we ensure quality care for everyone, everywhere, all the time. It is doable, and we're going to talk a lot about the ways to get there through the rest of this afternoon. And with that, and as I hand back to you, Monique, I've spoken long enough to have another 100 people online, so you have an even bigger audience to hear the perspectives of the bank as we move forward.
Thank you very much, Bruce Aylward, for those thoughtful reflections and compelling call to action. It is now my pleasure to introduce Monique Vleder, Head of the Global Health, Nutrition, and Population Department, the World Bank. Over to you, Monique.
Great, thank you so much, and thank you to Bruce as well. Of course, he took all of my talking points, so I can keep it short. First of all, I wanted to congratulate the team for this incredible achievement. This is a really, really important and impactful collection. And as you can see from the interest, even in this seminar this morning, there's going to be a lot of interest in terms of the implementation of the recommendation that comes out of that. So congratulations, really appreciative also of the collaboration with BMJ and WHO. As Bruce was saying, there's been a very large progress and undeniable progress in terms of the coverage of services. But unfortunately, and I think the maternal health outcomes are a really good example of that, increasing coverage does not mean that we see better health outcomes. And this is also why this collection is of such importance and relevance. We also see in the recent global monitoring report that access and quality of care is not the same for all people. And so we see a huge equity issue when it comes to accessing, including the financial barriers that people face to access quality care. And we saw in the recent report that the 1.3 billion people that have been pushed into poverty due to financial barriers and due to health expenditures. And so just coming back from COP28, of course, I also have to mention the impact of the climate crisis and some of the other risks that we are seeing that is jeopardizing more better outcomes and progress, including fragility and conflict. And so at the World Bank, we're looking at that in a system framework. What do we collectively need to do going forward? And getting the financing right, we're looking at the system's bottlenecks for quality of care, including rethinking our approach to primary health care and broadening the concept of primary health care, and looking and doubling down on the challenges related to human resources and supply chains. And of course, in this day and age, the opportunities we have, including with digital, to think in an innovative way how we move forward. And we very much look forward to do that in very close collaboration with WHO and our other partners. And so with that, I hand it back and thank you for the opportunity and really look forward to this important seminar. Thank you very much.
Thank you so much, Monique, for those very important reflections, including some of the threats that we face and the actions that we must take. I'd like to now introduce Kamran Abbasi, who is the editor-in-chief of the BMJ, to share opening reflections. And as mentioned, the BMJ, World Health Organization, and the World Bank are co-sponsoring today's webinar and the collection that has been launched today. Welcome, Kamran.
Hello, everybody. I'm Cameron Abbasi, Editor-in-Chief of the BMJ, and it's lovely to be here with you today. And I'm so delighted that so many of you have joined us. Thank you. I appreciate that very much. I'd like to join my colleagues in thanking everybody who put this collection of articles together. We've published 15 articles in the BMJ this year. 6 of those have been published today, and we're also going to be producing a podcast which will be available at the end of this week. So thank you to colleagues at WHO and the World Bank, to all the authors, the peer reviewers, the editors who helped put this together, and now to all of you for joining us for this webinar and hopefully for reading the articles. I think you will find something in there to interest you on this very, very important topic, one that the BMJ has been interested and involved in for well over 20, 25 years, just like WHO and the World Bank. We started out by publishing something called quality improvement reports over 20 years ago. And around that time, we launched a journal on quality and safety in healthcare, which is now called Quality and Safety. It still exists. And we are involved with IHI in a quality forum that we run every year. And we also have in Europe, and we also have one in the Asia Pacific. But what's interesting about those attempts that I mentioned that we've been involved in is that primarily they've been focused on high income countries. And what's so important about this collection of articles is that it's looking at at what we need to do in terms of quality of care in low and middle income countries. And that's where we can make a very, very big difference, and hopefully bring about improvements, because the whole movement around quality of care is built around improving service delivery, improving people's health and well-being outcomes, but also in eradicating the variations in the delivery of healthcare and the quality of care that people receive. And we all know that the most disadvantaged, the most deprived, the poorest in society, they receive the worst care, and that's a trend that obviously is worsening with time as well. If we move to today, what the BMJ is all about now is prioritizing outcomes related to health and well-being for people and the planet. So this topic is absolutely central to us. And that's why it's important, as other speakers have said, that we all campaign and we push and we work towards achieving universal health coverage. But we make sure that that universal health coverage is allied with a high quality of care that's delivered alongside it. And that's a very, very, very big challenge, particularly in a world in crisis, in deepening a perpetual crisis, for all the reasons that you've heard already. Things that may be out of our immediate hands, but certainly require political action. And that's one of the themes of this collection of articles. And I'm delighted that it didn't shy away from talking about the role of politics, because by taking the lens of quality of care, we can address some of the political issues, we can address some of the workforce issues, because we know that a healthy and a satisfied, content workforce leads to better delivery of healthcare, better outcomes for the population. It can also help us look at the desperate challenge we're facing in relation to inequalities. It also makes us think very carefully about being people-centered. And we know how the voice of people and the public and civil society was forgotten during the pandemic. So here's an opportunity to bring it back and think about it again and make it central again. So quality of care is important, it's central, it's essential. It allows us to tackle some of the big issues that we're facing in healthcare and in improving people's health and well-being. But it speaks very fundamentally to the values of the BMJ. And I'm going to read out the values of the BMJ because I think that will help explain to you why this issue matters to us so much. So our values are to be evidence-based, patient-centered, to be open and transparent, to be courageous, and to be proud of our people. And in particular, you need evidence and science to be able to advocate for improvements in care and to achieve improvements in people's health and well-being. And it's good to see that improvement science has really advanced over the last 25 years. Being patient-centered, again, is central to this whole tranche of work. And being proud of our people means taking care of the workforce, but also the populations that we're looking after. So this matters very deeply to the BMJ, and I'm delighted that we've been able to be part of this and offer a platform to our colleagues to publish these important reflections. It is a very, very key time because of the immense challenges the world is facing, but also the opportunity that we have to improve people's lives, their health and well-being outcomes, because there is the advance of new technology. With that new technology and those new data come new methods and new ways of answering questions. And also that leads to new thinking, new ideas, new solutions, and new innovation. So It's a central topic. These are difficult times, but there's a lot we can do. And it's exciting both academically, but also in terms of what we can achieve together for the people whose health and well-being that we are all working to improve. So thank you for joining us, and I hope you enjoy the rest of the webinar. Please do read the articles. I'm sure you're going to find something in there that will speak to you and help you improve people's care. Thank you very much.
Thanks very much.
Greetings. Thank you so much. I'm sorry, I'm having trouble putting on my camera, but I will go ahead and just do the transition. I'd like to thank you very much for those inspiring remarks, and also to thank you for the BMJ's longstanding commitment to quality of care. And as you know, this collection in particular focuses on the challenges and the opportunities in lower resource settings, and this is critical to address the huge inequities in quality of care worldwide. So it is now my pleasure to move us to the first panel. And I see that we have almost 400 participants online, and we thank you for joining and giving us your precious time. Our first panel on creating an enabling environment for quality of care will be moderated by Anshu Banerjee, Director, Department of Maternal, Newborn, Child, and Adolescent Health and Aging, WHO. Over to you, Anshu.
Thanks a lot, Kathleen, and it's a pleasure to be part of the webinar and to showcase the great work that has been going on. And this session around creating an enabling environment is particularly going to look at leadership, and there were a couple of articles in the series that highlighted the role of leadership in taking quality of care forward. So the enabling environment is supported by consistent and committed leadership to improve quality of care, and stimulates a culture of innovation and encourages engagement of all actors in improving quality of care, including strengthening the capacity of the health workforce to deliver this quality of care. And so we're delighted to have three distinguished speakers here with us today to highlight these issues. The first is Margaret Manna, who is the Program Manager for the National Quality Management Program at the Directorate of Reproductive and Child Health in the Ministry of Health and Sanitation in Sierra Leone. We also have Munir Kassa, who is the Senior Technical Advisor in the Ministry of Health in Ethiopia, and Selina Duse, who is the Acting Head for the Quality Management Unit in the Ministry of Health in Ghana. We'll first start with an analysis of the paper on leadership for quality of care that argues the importance of working in a co-leadership model at the national level. So my first question is going to be to Margaret. Margaret, quality of care cannot happen without commitment and effective leadership. And so in your experience, why is establishing effective leadership necessary to improve quality of care in your country? What is the role of fostering co-leadership across quality of care structures and health programs?
Thank you very much, Anshu, and good afternoon, everyone. Actually, the structure governs the function and organizational structure matters in delivering results. So in the absence of a clear leadership structure, roles and responsibilities get confused, they get mixed up, and this can drive a dysfunctional health system. So understanding the importance, Sierra Leone National Quality Management Program was established in 2018, and having a national leadership structure for quality of care that was in place ensured the focus on national priorities, where maternal and child mortality reduction was the vision that was set out by the program. Additionally, the existence of the National Quality Management Program in Sierra Leone led to setting the national quality agenda, the mechanisms to coordinate programs and partners in the quality of care journey, and also in the mainstreaming of quality in all programs, and develop tools for advancement of quality. This requires coordination of all program managers. Quality of care is actually everyone's responsibility, and a clear roles and responsibilities and lines of accountability are also required to organize and coordinate the work and deliver the results required. The factors that affect quality of care in health systems are very common. One is around human resource for health. The other one is commodities, drugs, and consumables. The other one is a very good referral system. So if we don't have those, these are common across every program, across every directory. So for this, co-leadership supports and strengthens the joint advocacy in national priority setting, in resource mobilization, and also domestic resource mobilization drive. Similarly, leadership is needed at sub-national level. So we realized the need for the sub-national level leadership structure. A governance structure was established at district and hospital level. This could not have happened without the establishment of the national program that actually accessed the need, advocated the issues, mobilized partners, and also programs that assured the availability of these governance structures at all levels. So in terms of sub-national level, we had the quality of care officers that were dedicated government-paid officers whose role is to lead the quality of care agenda at district level and facility level. Then also we have the QOC committees as well as the QI or improvement teams. These have clear roles and responsibilities at that level. So in conclusion, I really want to say quality of care demands person-centered, integrated health service that requires the organization and coordination across programs and other directorates to ensure that quality of care is given the right focus in all programs. Also, in quality, we need synergy between programs, not fragmentation. If we want to improve the health system to be safe, effective, efficient, and well coordinated, this cannot be possible without optimum co-leadership for quality of care, structures, and other programs. Coordination saves life. Coordination reduces wastage of resources. So co-leadership across programs also support in identifying and promoting neglected areas that is leading to poor maternal and child health outcomes, such as preconception care, respectful maternity care, and what have you. So quality demands accountability, co-leadership across programs. It improves joint accountability for addressing systems failure, contributing to poor maternal and child mortality.
Thank you very much, Margaret, and particularly for highlighting the need to make the link between national level and subnational level, and that leadership is needed at different levels, but also this issue about fragmentation and that there is a need to bring things together. For those who would like to ask some questions, because we'll have some Q&A afterwards, you can put your questions in the Q&A section. And there's already one question, and I hope that this will be answered actually by the next speaker. So the next speaker is going to talk about the paper which was focusing on importance of building a resilient and prepared health system to provide good quality care at all times. And Munir, from the Ethiopian experience, considering the lessons learned during COVID-19, why is strengthening capacities to deliver quality of care important for building health resilience? Over to you.
Thank you, Anshu. So thank you very much. I think there are important terms in in this question that I would like to go in 1 minute. How we see this in Ethiopia. So when we say quality, it can be a quality a healthcare provider, maybe thinking in a facility, or it could be a district and so on. But in Ethiopia, when we say quality, it's about a system, overall the health system's ability to provide care so that people would survive from diseases that could be preventable, from diseases that could be treatable. For example, in maternal health, it's not about a woman getting service in a facility, but it's about her ability to survive from that delivery with her child intact and enjoying life. So this makes it quality a broad health system overall action than a unit's action. And also it should be valued and trusted by the people so that people can come and use it. And one of the things we have in Ethiopia is our primary health care is trusted by the community, so people come and use it. Another term here is capacity. When we say capacity, it means the inputs to the health system. These are the health workforce, the facilities, the data, drugs, and so on and so on. So when we combine this, we get the new term, which is a very good term, it's resilience. And resilience is also a capacity, but it is, I see two types of resilience. One is when a system is able to respond, to prepare for and respond for any emergency, public health emergency. It's a resilience, but this alone is not enough. We call a system that's able to respond while maintaining essential functions. It's a system that's able to cope, but resilience demands robustness. I really like this term. The new term was robustness, where it's ability of creating a better system after the shock and being able to come better than where initially the systems were. And so this robustness can be it's this ability to recover from the shock after the event comes because of institutions. And so if a country has a good institutions, by designing and redesigning to adapt to a new challenge, I think is where we call now a robustness. And saying this in Ethiopia, so another thing is preparedness. And one of the things when I reflect about this question, so the rich countries, maybe they have COVID, and after COVID, they may not have that much challenge. But here in Ethiopia, we are in a perpetual cycle of public health threats. We have like the worst conflict in the past 40 years in Ethiopia. We currently have conflict which affects more than 20-30 million people. And we have various epidemics, cholera, malaria, and so on. So we are always in a perpetual cycle of public health emergencies. There is no time to prepare. But what we can do is reflect on what we did on one of the epidemic or one of the threat, and learn and go back. And when I see what we did, Ethiopia did, despite all these challenges, we maintained essential health services during COVID. And so there was not that much backsliding in nutrition and in vaccination, in other SRH functions, even though the challenges are massive and so on. The system was able somehow to provide these services. And one of the key reasons is, I think, our redesigning of our institutions. And we have a public health institute that we have redesigned, and now is improving surveillance and laboratory capacity and research, and also coordinating the response. I think we need such institutions. Another institution is our supply agency, where we are improving to last mile delivery and transparency of resources and so on. And this improvement in institution and improving in financing is what leadership should do. And saying this, I'll end in 1 minute. I think leadership is very critical, and leadership is critical to create these institutions like the ones I said, and others at regional and sub-regional level, but also very critically financing. So also we were able to get more resources despite all the challenges the country is going. The health is now getting much better resources, which can be seen as per capita expenditure, but also resources coming directly to Ministry for Family Planning and other services. I think these are the two important things: building better quality institutions and improving financing. And in the last word, I think efficiency is overrated when we talk about resilience, because our systems are chronically underfunded. And so the focus on efficiency does not work. It may work in other countries where there is lots of waste, but here to bring resilience, we need to invest and invest a good amount of resource. Thank you, Anshu.
Thank you so much, Munir. And yes, the issue of financing is indeed very important. We know that if we don't provide quality services, most likely the service will not have any impact. And so basically that investment is just going waste. So we will now go to the third panel speaker, and we would like to hear about the editorial that focuses on health systems strengthening and discusses an approach for consistently delivering quality healthcare to everyone, everywhere. So really looking at the equity angle, and I think that has also come up in the Q&As, and to look at, how do we make sure that this is part of addressing equity. So Selina, in your opinion, and from your work and experience in Ghana, why should quality of care and quality of care outcomes be considered as an integral part of any health system strengthening initiative and investment?
Thank you very much, Anshu, and good afternoon, everyone. I'm very much pleased to be here with you today. The effectiveness of health system as a whole and patient well-being are directly impacted by quality of treatment provided and the results obtained, making them essential elements of the system strengthening. It's good. Better health outcome, patient happiness, and systems trust are all enhanced by ensuring high quality of care. It also helps with disease burden reduction, improve healthcare delivery efficiency, and support preventive action. Putting money into high quality healthcare is crucial to creating a flexible and adaptable health system that can successfully handle both present and the future health issues. For us, when we look at patient-centered approach, we need to stress the value of giving patients top priority by delivering an excellent care, in addition to enhancing individual health outcome. A patient-centered strategy promotes health system trust. And in Ghana, we have put in place where we have patient complaint desks at each of the facilities where patients can be able to access to make a complaint if he's not happy about the system. We usually also have something we call the community scorecard. This one is open to community members that use a facility system, and then they come together to assess the provision of care, how they see the services that are being provided, and then they grade the services that they receive, either good, bad, or worse. We also have a system of doing a community thereby where patient thereby where patients come together to talk about the system or the health system they receive in our country. We also have a system where we do patient satisfaction survey, and these surveys are done every half year, twice in a year. This come out with challenges that patients face when they come to the facility, and this will help us improve our quality of care, because whatever our center is the patient. So whatever the patient complained about, it also give us the direction to improve the system. The next thing that we do in Ghana is the health equity. And then we need to emphasize how to attain health equity requires access to high quality treatment. In order to minimize gap in health outcome, a strong health system should generate that everyone, regardless of your socioeconomic background, has access to quality healthcare. And what Ghana is doing, that we have a strong primary healthcare system. The lowest one is the community-based planning services, where to improve the universal health coverage, we have community-based system, where a facility is located at least population of 500, have a facility where they can access. So equity of care is very, very important. This system is there for patient or community member to get strictly access to care at the base of care. And that is what Ghana is using. And then if you get there and then there's any referral, they can refer you to the next system. We also look at resources, how to get resources efficiency and optimization to be able to achieve initiative of an investment. So Ghana, we make a point of spending money on high quality treatment can improve how effective healthcare is delivered. A health system can become more resilient and responsive to requirements of populace by minimizing or maximizing resources and reducing errors. For Ghana, we have a strategic planning where we plan strategically. And for the Ministry of Health, we have the Health Sector Medium-Term Development Plan. And this plan directs us as to what our priorities are. So in each year, we need to work with our priorities so that we can maximize our priority, our work, our resources, and also reduce errors in what we do. If you don't have the planning and the direction, you can use the little resource, as we know, as a low middle income country, we can use the little resources and we may not be able to achieve what we achieve. So we have this medium-term development plan that directs us, and this also helps us to be accountable to what we have. Again, in improving and strengthening the system, health system initiative and investment, we need to look at the preventive services. We need to look at how we can get access to healthcare and reduce disease burden. This is by supporting preventive services. Long-term cost saving and improved population health can result from proactive health intervention. And here in Ghana, we have our system, a strong health promotion system in place, where we have a lot of health talks on radios, communities, and others. We have our strong vaccination system, where we vaccinate a lot of people, whether the children or the adults, on other vaccinations. We also screen people for non-communicable disease and then communicable diseases. We also do cervical screening, diabetes, eye screening, ENT. For our system, we make it a point that when the child is delivered, you go through all this screening so that we can prevent later development of serious condition that will put a burden on our system financially. Now we have a strong system also in place. That is our data analysis or health information system. We use this data to measure and enhance the results, high quality of care. Using data-driven insight can result in evidence-based decision-making, which promotes ongoing practices, improve in healthcare industry. For us in Ghana, we use the DIMS, that is the District Health Information Management System, where national data is being put in there from the private sector, from the government sector, or all the health sector's data. This enables the system to track the quality improvement activities that is going on. We also track mobilities and mortalities so that we can work around to reduce our mortalities and mobilities, to reduce the cost burden in the country. We also use this data to make decisions and make policies accordingly to what we need to do. We have another system in place, which is public health preparedness or emergency preparedness. We all know how COVID came to hit the system, and I think it's not Ghana alone, and it has taught us a lot of lessons, how to put systems in place. So Ghana has put a system in place where we have a national infection prevention and control team in place, disease management system in place. We also have built isolation center, infectious disease centers in the national, and every region has that infectious disease center, so that when there's an outbreak, we all move to be able to save the situation. This link access to high quality of care system, capacity to manage a range medical emergency. When it comes to responding to new emergencies like epidemics, a system based on high quality treatment is more to prepare. The next thing that we will talk about is health workforce. We cannot do all these things without talking about health workforce. It is very, very, very important that we look at the workforce that are going to help us to be able to achieve quality of care. Putting investment in quality or health workforce is very, very important. We need to train health workers and staff on a high quality level so that they can provide the services that we need. If we are able to achieve high quality of service and health workforce that have been developed at the high level to promote this, it will help Ghana. Again, what we have put in place, we have a strong system of pre-service, the post-service, and specialty areas where we develop our health workforce to be able to take responsibility of all the system that has been put in place. The next thing that I'll talk about is about technology and innovation. Now, Ghana have access to medicine, essential medicines. Ghana, we have a telemedicine system in place. We have drone system that deliver essential emergency drugs to our people in the hinterland. For this to be able to improve the community access to services that we want. And then we have a national ambulance system that help us in referral and move people from the rural community to urban or inter-urban, moving a patient from one facility to the other when he needs services.
Thank you,
The last
Selina.
thing that we can talk about, we can talk about is the policy and governance system. The policy and governance system, Ghana has quality healthcare strategy in place. We have the patient safety strategy. We have leadership commitment, and that is very, very important. And then leadership accountability. Leaders are held accountable to be able to deliver quality health services in the various agencies. For this, we will be able to achieve the resilience that we want, and then innovative that we want, an initiative in investment to strengthen the health system. Thank you very much.
Thank you so much, Selina. And I think you have answered a couple of questions in the Q&A around accountability and also around involvement of patients or the patient's perspective of quality of care. So the questions in the chat, please continue them. They'll be answered as we're going on. And I hand back to Kathleen.
Thank you very much, Anshu, and thank you to all the panelists of panel 1 for very, very important and interesting reflections. Just to reiterate Anshu's note that we will actually, because of time constraints, we're going to keep moving, but we will plan to use the online discussion forum, and we'll paste that link again in the chat, and we'll use that forum to answer the questions that have come in, many of which are very important. So it is now my pleasure to hand the baton to Blerta Maliki, who will moderate our next panel on engaging for quality of care. Over to you, Blerta.
Thank you very much, Kathleen, and thank you to all the previous panelists for their thoughtful messages and experiences. So the second panel is about engaging for quality of care. Engaging stakeholders is critical for achieving quality of care goals. And for that, an enabling environment creates a space to engage and maximize the contribution of traditional stakeholders, such as communities and health workforce, but at the same time of new ones, such as private sector. So for this panel, we are privileged to have 3 distinguished speakers and co-authors in the collection. And I would like to welcome Dr. Bongani Chikwapolo, Head of Norms and Standards in the Quality Management Directorate, Ministry of Health, Population and Population Malawi. Dr. Rajat Chaba, Technical Director in Market Solution, JPIGO. And Minara Chowdhury, Senior Director, Institute for Healthcare Improvement. Thank you very much and welcome. And if you can turn on your cameras, we'll appreciate. So the session will cover 2 analysis papers and 1 opinion piece. The 2 analysis papers are on community engagement and engaging the private sector for quality, and the opinion piece is about motivating the workforce to deliver quality. So let's start with the first analysis on community engagement, and the paper is Institutionalizing Community Engagement for Quality of Care, Moving Beyond the Rhetoric. Bongani, the question is mainly for you. So despite the evidence and the guidance that community engagement is critical for quality of care, its robust integration into health systems is still lagging. Now, based on the analysis paper and your experience in Malawi, could you please share with us what needs to be done to ensure this happens? And please keep it within 4 minutes so we can move on with the other panelists. Thank you. Over to you.
So thank you, Blerta, for the opportunity for Malawi to share its experience So how do we move from global guidance on community engagement and national guidance on community engagement to effective community engagement? So first of all, I think we need, the countries have to deliberately strengthen leadership at all levels, leadership that will champion community engagement and leadership that is accountable for community engagement and is rising community engagement in the healthcare system. Countries also need to strengthen monitoring and evaluation systems for community engagement efforts. We're still seeing gaps in terms of documenting how community engagement processes are being done in different countries. And also, most importantly, we need to have M&D systems that are assessing whether community engagement processes are actually meaningful. So people are being engaged from identification of priorities, planning, delivery, and evaluation of service, delivery of service. And gaps that are identified are used to improve the community engagement process. And we also need to see a strengthened linkage between community feedback mechanism to QI initiatives. For this to happen, data that is coming from community engagement processes, feedback mechanisms have to be visible to community members, providers, policymakers, for them to be able to act and improve healthcare delivery. And as you're aware that engagement of the community is not cheap, countries have to invest in terms of financing, HR with the right technical capacity to conduct community engagement. So just to share a bit about our experience in Malawi, the government has established different structures for community engagement at community level. So we have the village health committees, health center management committees. We have got the hospital ombudsman. So hospital ombudsman is a focal person that is at each and every health facility and is responsible for resolving challenges from service users and routinely conducts client satisfaction surveys. There are still gaps that we're still working on, and we're learning and trying to strengthen. So we've gotten feedback around the hospital ombudsman program, and there are plans, feedback around independence of that focal person, and there are plans to conditional reform that complements feedback mechanism. There have been gaps in the general M&E system, and as a country, we're developing an integrated community health information system to ensure that we are effectively monitoring community engagement processes. And there's still, as much as there is guidance at national level, there are still parallel structures of community engagement efforts impeding institutionalization. And at national level, we have got the community health department that is mandated to align everybody in terms of community engagement process. And this is a continued struggle to bring all stakeholders and to continuously improve the engagement processes that are available. And just to conclude, institution of community engagement is a process, and the countries have to be honest with the gaps and where they are, and they have to take deliberate steps to ensure meaningful community engagement for improving quality of care. Thank you very much. Back to the moderator. Thank you.
Bongani, thank you very much for your answer, and thank you for keeping on time. So by keeping on time, I would quickly like to move to the next discussion, which is about the involvement of another very important stakeholder, the private sector. The paper on delivering quality care to all mothers and newborns requires government to engage the private sector is one of the analyses that sheds light on this. Rajat, you are the lead author of this paper. We know that all the health systems are mixed systems consisting of public and private sectors. Based on the analysis paper and your own experience, why and how should governments adopt a more structured approach to engaging with the private sector to improve quality of care?
Thanks a lot. for the question, and thank you everyone for the opportunity. I think to answer that question, it is important to emphasize that private sector, how critical private sector is currently in the mixed health system environment. In many of the low and middle income countries, private sector is often the first point of contact for women, men, and children seeking healthcare, and also a critical source of quality health products and services. Add to it that more than 40% of services for antenatal care as well as childbirth are within the private sector in these low and middle income countries. It makes critical and important for both public and private sector to collaborate and work together. However, the different analysis and even WHO's own 2020 PSC analysis has shown that governments often struggle to engage in a structured manner with the private sector. There are many reasons. I think primarily because of the vastness of the services to be delivered, there is an increased emphasis, and rightly so often, on engaging and strengthening the services in the public sector, which often leaves private sector out of consideration. Also, there are limited policy frameworks and limited government expertise and experience within the key stakeholders to actually how to engage the private sector. And a common lack of understanding on both sides in terms of the intentions and the incentives and how to align them around engaging with the private sector. Having said that, that means there's a critical need for us to engage, and there are opportunities to engage structurally, and many countries have actually demonstrated and taken leadership on how that can actually be done. We found that there are three key avenues or area pillars through which this can be done. The first one is agreeing on common goals and designing interventions which help you achieve a successful common outcome around quality of care. This was especially quite evident during COVID, where private providers helped to sustain essential services, ensuring the surge capacity that was needed to deal with the increasing health system burden. A good example is actually from Mexico, where the Mexican Institute of Social Security contracted out private hospitals to provide childbirth services during COVID-19. Another pillar and opportunity for structured engagement is actually around developing and implementing policies along with the private sector. There are a couple of great examples to learn from. One around immunization in Sudan, where the Federal Ministry of Health included private providers to immunize children as part of their national immunization strategy. When it was done in 2017, private sector actually delivered almost 16% of DPT vaccines during that year and contributed to increasing the immunization rates from 62% in 2000 to 95% in 2017. So it's a good model to actually look into. The other good example actually comes from Ghana, and I think someone had earlier spoken about it, where Ministry of Health has a MOU with CHAG, the Christian Health Association of Ghana, which is the largest faith-based provider in Ghana, covering almost 30 to 40% of health services being delivered in the country. That allows them to participate in government decision-making process. They're also reporting data into the government health system. So creates a collaborative environment to delivering services around that. And finally, many panelists have actually in the previous session as well mentioned to this around leveraging financing. I think this is the great accelerator, and there is an unmet need around that in terms of how can we leverage more financing mechanisms such as tax rebates, loans, guarantees, impact bonds, blended finance to actually engage private sector in a more effective manner. In Cote d'Ivoire, Global Financing Facility actually supported private providers to form an umbrella organization and use result-based financing for delivering quality care for maternal and newborn health as a key outcome. There are other examples of similar impact bonds in many countries as well, which have given positive results. I think to conclude, there are a couple of things. The scale, reach, and leadership of the public sector, along with the flexibility, innovations, and resources that we can actually bring, the private sector brings in, they can accelerate the progress towards quality health services. Having said that, we need more data, and we need further research to urgently help identify the effectiveness of these strategies in different country contexts, because the private sector is different in different countries and has different level of maturities. So I think there are promising results, but we have just started and there is a long way to go, Berta, on this one. So back to you. I hope I stuck to my time.
Thank you very much, Rajat. I know that there are questions about this, but as time is pushing, I would like to shift to Minara. And Minara, from your side, you have co-authored and led the development of the opinion piece on a motivated workforce is needed for quality improvement efforts to succeed. So based on your opinion and experience, could you please share with us why should healthcare systems invest time and effort to engage the workforce in quality improvement? And how is that different to just managing the daily work? Over to you, Minara, 5 minutes, thank you.
Thank you so much, Blurta, for that question. So I guess we have to start right at the beginning, which is that in healthcare, our workforce is our biggest asset and our most important resource. And in the evolving nature of healthcare, as there are increasing demands placed on our workforce, especially in low middle income countries, we have limited resources and more demands on the health system. We have to find and actively find ways to keep our workforce motivated. So one of the ways which really supports that motivated workforce is engaging them in conversations around how to improve services, service provision, service delivery. It's a way to empower our staff and provide them with an opportunity to actually shape future services or current service provision, instead of just having a new intervention, a new design, a new solution being implemented on them. It's much better to be implemented with. So I guess the healthcare workforce really does understand how that system works. What are the positive aspects of that? What are the things that don't work? And they're the best person we can learn from. So again, leveraging on that knowledge, that guidance is really important for us as we design quality of care interventions. And engaging the staff in those discussions really helps to motivate the staff and keep them on board. And actually, by trying or testing or piloting, depending on how we articulate that, they can really be involved in the process and less likely to be resistant to change because they're actually helping to co-design and co-create those solutions. So our experience from Bangladesh was exactly that, and we actually learned that through the introduction of MNHQI bundles, maternal newborn healthcare bundles, through USAID's Mamoni MNCSP, we learned that we could really invest in our workforce by providing them with the skills, the training, but actually working with them to understand which aspects of the bundles are the highest priority, how we should design a new form, how we should design a new intervention, what works well, how we can approach our clients, how we can approach other members of staff for inputs. It worked really effectively. And we had a lot of updates, so those particular interventions were implemented in a number of facilities throughout the country with great success. So I guess in summary, when the workforce is motivated, they can truly commit and contribute to achieve outcomes, quality outcomes within the healthcare system, and really help us to design solutions that are right and fit for purpose. I'll pause there. Thank you. Blurta, we can't hear you.
I just saw it. Sorry. Thank you very much, Minara. Thank you to all panelists. The chat is very live with questions. Many of them are leading towards accountability and how do we create the environment to demonstrate accountability. And for me, I know I want to ask you a few questions, but given that the time is pressing, I just would like to orient the participants that the engagement part and creating the conditions for the engagement. Be that with the health workers, creating an enabling environment for health workers to be able to improve quality, to demonstrate quality, and to have that culture of quality. Engagement from a perspective of users and communities, to define the quality, to create the mechanisms for demonstrating accountability and keeping people accountable, but at the same time be able to participate in a way that leads more than just the solutions, but solutions that are important and relevant to the context. And finally, the engagement with engagement with those who are really providing the services, be that public and private, and having a joint accountability framework around accountability across sectors. So not only on public, not only on private, but on health. Those are three directions that we would like to continue to work and engage with countries, as they are the most promising in terms of not only defining, but giving results. So with this, I'd like to close this part of our panel. I'd like to hand it over to our MC Kathleen to lead us in the last panel for today. Thank you, Kathleen. Thank you, everybody.
Thank you very much to panel 2, to our moderator Blerta, and the panelists for the very insightful reflections. And we do encourage you to read the papers, which have been posted into the chat with the links. And also, I want to thank our participants. There are many really interesting questions, observations coming in through the Q&A button, and I encourage you to review those, as well as the answers that are being provided by many of our panelists and moderators. And then again, to reinforce that we will have a continuing online discussion platform. So without further ado, it is my pleasure to welcome Sanam Roder Dewan, who will be moderating our next panel focused on innovating for quality of care. Over to you, Sanam.
Thanks so much, Kathleen. And if Dr. Ayeem and Mickey and Hema could please turn on their cameras, I would appreciate that. It's a real privilege to be here and moderating this particular session, which includes 3 people that I've had really the privilege of learning from and working with for many years now. So really grateful for this opportunity. Innovation is really a key part of improving quality of care globally. It's the engine that will push us towards really accelerating progress, which is so desperately needed in many places. It's also an opportunity to highlight and see the creativity that colleagues, especially at the country level, have around making change. So excited to open up this panel now. Our 3 speakers are Dr. Andrew Zaim, who's the Deputy Director for Policy, Planning, Monitoring, and Evaluation in the Division of the Ghana Health Services, and really a key innovator around networks of care. Our second speaker is Dr. Mickey Chopra, who is the Global Solutions Lead for Service Delivery in the Health, Nutrition, and Population Global Practice at the World Bank, and really pushing that institution to think forward on quality of care. And then we have Dr. Hema Mage, who's a Senior Program Officer for Newborn Health at the Bill and Melinda Gates Foundation, also challenging the global community to think differently and to measure effectively around quality of care. So my first question will be to Dr. Ayeem. We could turn the slide over to the introduction. So Dr. Ayeem is a co-author on our analysis paper led by Oti Agiakum and Catherine Caleres on networks of care, where we really think about the application of networks to primary health care in resource-constrained settings. And I've had really the honor of hearing Dr. Ayeem speak about this topic several times, and would love to hear you speak again about Ghana's experience with and vision for scaling up primary care. And specifically, if you could touch on the role of relationship building and local adaptation around Ghana's core model of primary care networks, would greatly appreciate that. Dr. Ayeem, over to you.
Yes, thank you very much. Greetings from Ghana to everybody who is listening. Yes, we were very happy to continue about 2 decades of our community work, which is our collaboration in the community through the community-based health planning and services program, which we call the CHIPS. and where nurses could go to home visits, could collaborate with the communities, and could do more with them. But we realized that when it came to the patient-centeredness, the issue came up where the patients started demanding certain services that they thought was too far from them into the hospitals. Because when you take our primary healthcare system, we have the district hospitals, the sub-district level, which are the health centers, and the CHIPS compounds. But this demand for delivery services, that was a little further, was demanded by the people, and they wanted it to come close to them because they were already doing even home deliveries and all that already. So they thought if the health system wants to get close to them, then we should get close to them. And therefore, the concept of CHIPS came up. Then we had the experience where we realized that some of the CHIPS compounds had different human resource capacities, different equipment capacities, and the health centers were also weak. So we decided that to respond to the people's quality concepts and the people's philosophy about health, which in their opinion, they thought if it is close to us, then it must be good if it's supplied from us. But if it's so far from us, then we are going to struggle to get there. And the cost of getting there, we should get some local resources to do. So now the health system decided that let's follow the people to where they are. And therefore, we looked at the issues and decided that, okay, the new way of looking at it, between 2017 to 2021, let's experiment on how the facilities can network. When we decided to experiment, we realized that there were very key issues where the service delivery there and the perception of the clients in terms of quality was based on the values and norms, the informal rules, the relationships and the communications at that level. So when we set out to move, we realized that the only way we could deal with a new policy was to make it a bottom-up approach so that the relationship at the lower level, we cannot assume at the top level that we can legislate it or we can make a policy on it. So we agree that then let's start from there, let them start forming it, let's give them the basic concept, and so that the variability in our country for the north, for the middle belt, and for the lower belt can come into bear whenever we look at the policy and we write the policy. So this one came from practice to policy writing, where now the practice will inform the guidelines that would make it national. So that issue of relationship, where at the local level they had their own ways of looking at things, became an important issue in the policy direction. And therefore, we started looking at it. And the truth was that at the top, there were relationships in terms of religion, relationships in terms of communities, relationships in terms of policies, relationships in terms of politics. And all these were very detailed on the ground, where at the top we couldn't have legislated it. So we made them all run it so that gradually as they run it, then we pick up some of these issues and then we can put it into clear policy guidelines and we look whether we can nationalize even some of the relationship concepts, or we should open it up for a national system or just a local policy concept. So we looked at all that. Then we looked at the structure we already had. And the structure we already had was important for the relationship because already we had this thread tie, the district hospital, the sub-district, and the network and the CHIPS compound. So we decided that then to enhance a better relationship, let's now bring them together at that level using their old structure so that they could still fall on their old concepts and their relationship. The other interesting issue was local resource mobilization capability at that local level. They had their own ways of doing things. And in some of our places, I would say that the relationship was so important to a level where they were able to work with the local delivery systems so that service delivery and then the local midwives could work together so that even the payments were during the outdooring of the child. Then people bring gifts and pay the midwives. And such a thing, we couldn't have written the policy up. So we've come to understand that the network of practice, which we are trying to bring all the facilities in a geographical area together to deliver service and share in resources, has become a very important thing. And that is why the bottom-up approach to our policy and the relationship concept has become such an important concept in this particular implementation.
Thank you.
Rather from the top-down approach. Thank you very much. Over.
Thank you. The art of everything. Great. We're going to switch there now and turn over to Dr. Chopra. So he participated in a paper on service delivery redesign that really talks about a process of developing models of care and models of care themselves. I wonder if you could speak a little bit more about that. Thank you. And if we could switch the slide over.
Thanks, Sanam. Your voice broke up a bit, but I think I got the question around models of care. Now, yes, you know, the Lancet Commission on High Quality Systems, one of its great innovations was to point out actually that a lot of the innovations around quality of care, particularly at what they called the micro and meso level, at the health worker level, whether it was new apps or whether it's even mentorship and coaching and QI, a lot of that evidence is systematically reviewed, shows very small size effects. And they actually drew attention to something that Dr. Aim has just been highlighting, which is what at the systems level, how, you know, what's been missing and underappreciated is the way the system is organized. And networks is one great example of thinking in a systems way about how to think about and tackle the quality of care issue. So service delivery redesign is that sort of intentional reorganization of a health system to improve equity, quality, and outcomes. And it's something which is gaining a lot of traction in many different settings, and particularly amongst colleagues in the World Bank, where we sort of do focus on health systems. There has been a tendency, though, in some places to equate that with the model of care, you know, of sort of all delivery should be happening in hospitals. So what we've been keen to do is to emphasize that service delivery redesign is about looking at a systems perspective. It's also something that Dr. Aim mentioned as well, which is taking out from the bottom up, and it's something that was also mentioned in the previous panel as well. So, for example, in Meghalaya in India, where we give an example, they've taken a deliberate approach to say, okay, for complex conditions such as childbirth, we really need to get as many women as delivering within 30 minutes of a place where they can offer comprehensive obstetric care and take care of complications and so forth. And that spewed a whole lot of innovations, such as recruitment with having a relationship with another state, with Tamil Nadu, to get doctors to come up and some key nursing staff as well. They've had other innovations such as waiting homes, maternity waiting homes being tried out. And also we've been working with colleagues in the World Bank to look at roads and infrastructure. So this systems approach to thinking about qualities, particularly at the scale level, can really unlock and unleash a whole lot of innovations, which are not the traditional ones that we think about when we think about quality of care. So I'm really excited that we've got this series to really put on the table some of the early lessons and insights that we're learning from more of a systems approach to quality of care, and in particular this sort of shift to participatory approaches to human-centered design, but also to looking at you know, geospatial aspects as well. Maybe just to finish then with a couple of key principles, if you like, which should shape and prioritize innovations, because innovations is something which is everywhere these days. And so one challenge is indeed, how do we prioritize? And in the paper, we highlight 4 principles, if you like. One is start with those who have the worst quality of care and the worst access to care. Prioritize their needs, and innovations that are going to help improve quality and reach for them. Another one is shift the more complex and centralize the more complex interventions and life-threatening conditions that affect life-threatening conditions to places which are well-equipped and have the turnover and staffing or require just a little bit more to get that is going to be, you know, it makes sense and it works if you're going to try and do it at scale. The vice versa is that as you can localize and decentralize conditions and interventions which are not so complex. So the one example we give is a lot of the things around non-communicable diseases, which are currently being treated at the hospital level, could well be decentralized. And we can learn a lot from the HIV experience here as well. They've been very good at this. And finally, the importance of using evidence and generating evidence and learning as we go along. So in summary, Sanam, a really exciting piece part of our work right now is helping countries and teams think in a more systems approach, think more about human-centered design, but also a learning agenda going along with that. Thank you.
Thanks so much. Hema, spent many years in implementation research, so much to say, but if you share some examples of embedding research has been used to research quality with great. Thanks.
Yeah, happy. I'm happy to. I hope my audio is clear. And unfortunately, I think Sanam, your voice was a little bit breaking up, but I was able to hear the question. So I think that there are two prevailing theories that embedding implementation research is in direct contrast to. And I say this kind of cognizant that I think many of the institutions that this is largely the responsibility of many of the donor agencies as well. And I think one is that the concepts of rigor and discipline are principles that apply only to research and not to program design or delivery. And I think another prevailing theory that embedding research is in contrast to is that the idea that rigorous and unbiased research must be designed and led entirely separately from implementers. Frankly, I think these two principles are in many ways really underestimating the level of discipline and work that it takes to design programs well and effectively. And I think they hold kind of methods and research to be somewhat in a fairly charmed world that lives very separately from the really hard work of trying to figure out how to improve and deliver high quality care. So I think those are two principles that I think I was really thrilled to be part of this effort to talk about this concept of what makes implementation research really effective and useful as a set of tools, and that is actually to really embed those skills into various institutions, whether it be the government that is, and deciding on policies, or in key technical partners that may be working very closely with health system actors in improving care. So in terms of, as an example, I think some of an example that is documented in this paper is in the context of COVID-19. And so I think this is a important shock that's been mentioned in a number of the questions that have come in through the chat around, and I think it was a real wake-up call to say, okay, there's this this huge shock to our health system. How do we respond? And I think the only way you'll respond is if you've already got those skills and methods somewhat embedded in folks who are there facing the challenges directly. In one of the examples that we talked about, it was looking at particularly at newborn health. And this was sort of with the basis that modeling had been done already and conducted using the LiveSafe tool, showing that the disruptions to the health system due to COVID-19 shutdowns was predicted to lead to significant excess neonatal mortality, with the largest driver of that being neonatal sepsis. Yet in this current, we also have tools that are community-based to diagnose and treat neonatal sepsis, and that's with outpatient treatment and management of possible serious bacterial infection, or PSBI. And so we were able to provide resources to partners to basically looking to say who is already embedded and has these skills and to actually design and implement approaches that, together with communities, that might be able to strengthen quality of PSBI management in the context of COVID-19 disruptions. And these are described in detail in the paper in Ethiopia and Kenya. And so that's kind of my quick response to your question, Sanam.
Thank you, Hema. Thanks so much, and more in the paper for sure. Okay, I want to thank our speakers and turn back to Kathleen.
Thank you very much to our panel 3 moderator and panelists for the very interesting discussion. And again, we invite you to review all of the articles online and the Q&A session. It is my pleasure now, on behalf of WHO, World Bank, and BMJ, to move to our closing remarks. We also invite you to review some of the articles. 6 of the 15 articles were actually published today and cover additional and very important themes related to measurement, politics, and many other issues that are very relevant to the discussions we're having. So I'd like to turn it now to Rudy Eggers, WHO Department for Integrated Health Services Director, and to Juan Pablo Uribe, Global Director for Health, Nutrition, Population, and Global Financing Facility, the World Bank, to provide us with closing remarks. And on behalf of all of our participants, I thank you for participating today. It has been a pleasure and an honor to be the moderator. Thank you.
Kathleen, hello. This is Juan Pablo Uribe. Can you hear me?
Yes, we hear you loud and clear. Thank you.
Okay, I'm trying to put on my camera. Now that the co-host authorized it, I'm here. I'm going to be very brief. But one of the important things of quality improvement processes, by the way, is to always give a huge appreciation to the teams for their efforts and to say thanks. It's part of the quality culture and an important one. So I want to start by thanking you, Kathleen, for being the master of ceremony and doing so, by the way, with such a high quality. I also want, of course, to thank all the participants, everybody in the audience, and incredible participation as reflected in the chat. It is very exciting to see the interest and the commitment around quality of care. So to everybody in the audience, thanks for taking the time to join and listen to these incredible panels. Of course, to the panelists and the moderators, a huge thanks. You've been very generous in sharing not only facts, but also actions at the country level that bring important lessons to all of us. I want also to thank the co-authors who have conducted the analysis. They have shared their honest opinions, their best thoughts, and they're pushing all of us in thinking in stronger and more deep ways on how to improve quality of care. Of course, a huge thanks to WHO. I was able to listen to Bruce at the beginning. So to all in the team of WHO, our recognition for your leadership and your commitment. And we really value the partnership that we have on you. I also want to thank BMJ for the trust and willingness to bring light and give visibility to such an important topic. Access to healthcare without quality is an unfinished promise, as Donald Berwick used to remind us every time. Now let me, with these thanks, turn it over to Rudy. Rudy, over to you.
Thank you, Jean Paulo. Good afternoon, everybody, and thank you very much for participating. Thank you for those kind words and all those insights that we've received from everybody across the world. Mine is just to give you a little bit of perspective looking forward. Obviously, it is very clear that we need to work to strengthen health systems to deliver quality of care at all times, in any case, in every place, everywhere. Just to quote Dr. Tedros, our WHO DG, quality is not a given. It takes vision, planning, investment, compassion, then meticulous execution and rigorous monitoring from the national level to the smallest, remotest clinic. Tomorrow we have UHC Day. 12th of December is always UHC Day. And as we strive to achieve health for all, we are all engaged in finding solutions to very complex problems, including combating climate change and to mitigate its negative impact in health. For this, we need health systems that are strengthened and able to respond to these changes. Health systems that are able to deliver quality are resilient. With this BMJ collection, it is a clear reminder that we need to invest and innovate so our solutions are sustainable and improve health for everyone, everywhere, all the time. We would like to close by calling on everybody, healthcare practitioners, policymakers, scientists, activists, donors, everybody, to continue to invest and strengthen health systems that are able to enable, engage, and innovate for quality of care as the prerequisite for resilience and impact. Please, would you continue to follow us and engage in the community of practice, discussion groups, and media. Thank you all, and back to you, to the moderator.
Thank you so much for those inspiring final comments. And it is my pleasure now, on behalf of the BMJ, WHO, and the World Bank, to thank you for taking your precious time to participate in today's launch of the BMJ Collection on quality of care. And to wish you well, please do join the discussion platform, which is available through this link, to continue the discussion virtually. Many thanks.